So, thank you, ma'am. So, I will be briefly discussing the diagnosis and management of retinopathy of prematurity. So, all of us, we should know the Indian ROP screening guidelines given by the Rashtriya Bal Swasthya Karyakram. So, all infants with birth weight less than 2000 gram or gestational age less than 35 weeks, they need screening for ROP. And if there are older infants like somebody born at 36 weeks, 37 weeks, if receiving prolonged oxygenation or having circulatory disturbances, they also need screening for ROP. So when to do the first screening of ROP? So as a simple rule, as a resident, you should remember that the first screening should be completed by 30th day of life, usually between 3 to 4 weeks of the birth, irrespective of the gestational age. So this is what you should remember. And what are the basic steps? So the ROP screening can be done in the nursery itself, or it can be done in the OPD. So baby should be fed and burped an hour prior to screening. So proper aseptic precautions should be maintained. So as a simple thing, so how to dilate the babies? So we have the commercially available tropicamide phenylephrine combination. So this can be diluted in equal amounts of distilled water or methylcellulose eye drops, and this will give us a half the effective concentration, which can be instilled twice after a gap of 10 minutes. And if you have engorged vessels like tunica vasculosa lentis, here we are seeing that pupil may not dilate, and we should not be overusing the drops because this can lead to systemic side effects from the dilated drops. And so what is important here is that the screening can be done usually by a trained ophthalmologist who is well versed with ROP screening, or at least he's a retina specialist who is doing intract ophthalmoscopy, or a pediatric ophthalmologist well versed with the ROP treatment. And the baby should be properly wrapped, so it is easier to hold the baby. So, and it can be done in the nursery, it can even be done to the wall of the incubator, and we can use our hands to prise open the lids, use a 20 diopter lens or a 28 diopter lens to examine the babies. And if we are not comfortable, and sometimes a lot of people use the speculum, wire speculum, and a wire vectis for examination. And if you have to do that, you have to have topical proparacaine eye drops before that, and installation of antibiotics after the examination. So what do we see when we do a ROP screening? So with the 20 diopter condensing lens or a 28 diopter lens, so we look for the media opacity, tunica vasculosa lentis, dilated iris vessels, extent of pupillary dilation. So these are the interior segment things which we look for. And the posterior pole, as well as all around, we have to examine the retina. So the classification of ROP has been revised. So this is the latest classification of ROP, the third edition. And stages of ROP, they remain the same. So on the top left hand, we are seeing the stage 1, which is called as a demarcation line. Adjacent to it, we are seeing the stage 2 ROP, that is called as a ridge. And lower down, we are seeing stage 3 ROP, that is ridge with extraretinal fibrovascular proliferation. And this is an example of, on the left hand side, this is 4A detachment, that is a extra macular detachment of retina. 4B is a macular detachment. And stage 5 ROP now has been revised into stage 5A, which is a open funnel total retinal detachment. Stage B is a closed funnel retinal detachment, and 5C is a kind of a closed funnel detachment with interior segment changes, like you're seeing here lower down, like corneal edema or ectropia and UVA. And these stages actually prognosticate. So the surgery will have the best prognosis if we were to operate at stage 5A ROP. And these are the various zones of ROP. Zone 1 is roughly twice the distance from the optic disc to the fovea. So if we draw a circle parallel to it and passing through the nasal ora serrata, so this is the extent of the zone 2, and the remaining crescent is the zone 3. So The classification also denoted neo terms like zone 1 secondary to notch and immature retinal vasculature to denote the avascular retina. And so what is most important to look for in the posterior pole is plastices. So plastices, what does it mean? It means dilation of the uh, arterioles and tortuosity of the venules in at least 2 quadrants of the retina. And if we have a tortuosity which is little less, so this is called as preplastices. Now the newer classification has given a whole, kind of a list and standard photographs to donate a continuous spectrum of plastices. So plastices is important to decide about the treatment part, as we'll come to later on. And another type of ROP which is there is called as aggressive ROP. So this does not follow any stage-wise pattern. So there is no stage 1, 2, 3. Here we are seeing flat neovascularization at the junction of vascular and avascular retina. And so this basically is a disease which aggressively, if not treated, aggressively progresses to stage 5 ROP. And in our country, it may be seen even well beyond the zone 1 in the zone 2. That is why now it is not called as aggressive posterior ROP, it is called as aggressive ROP. And we have various variations like blab-like ROP. This is a variation of aggressive ROP. And we also have a variation where we can see both the stage as well as features of aggressive ROP in the same eye, which is called as hybrid form of ROP. And if you look at the treatment guidelines, these are given by the ETROP study, early treatment for ROP study. So if in zone 1, if we have any stage like stage 1, 2 or 3 along with plastices, so they need treatment. In zone 2, we have stage 2 and 3 ROP. With plastices, it will require treatment. And any kind of, in zone 1, even stage 3 ROP, there may not be plastices. And there may be aggressive ROP, they need treatment. And both diode laser as well as green laser is available at most places for treatment of diabetic retinopathy. So green laser can be used with equal efficacy for treatment. And this can be done in your OPD setting also along with the neonatal team. So here we are doing the LIO laser for ROP along with the neonatal team, and it is done under topical anesthesia, and we have the monitor attached to the baby, so the saturation monitoring also going on simultaneously. So the aim is to create near confluent laser burns less than 1 bit apart, and so from the ridge to the ora serrata. And sometimes if we have severe stage 3 ROP, we may apply 2-3 rows of laser posterior to the ridge, as we are seeing in the lower panel here, and this can give us good results in stage 3 ROP. And as far as the intravitreal anti-VEGF injections are concerned, they are usually reserved for severe form of ROP, that is aggressive ROP. Like this aggressive ROP, earlier we used to do laser in aggressive ROP, but laser only had about 70% favorable outcome in aggressive ROP. So in aggressive ROP, usually nowadays, we do a combination of anti-VEGF treatment as well as the laser treatment. And this is the most severe form of ROP, which we call as posterior zone 1 ROP, where we are seeing very, very few vessels which are budding from the optic disc. And this usually, invariably, laser treatment fails in these cases. So here, anti-VEGF is a must prior to a combination laser treatment. And other indications are increased vascular activity despite laser, poor pupillary dilation, or media haze due to vitreous hemorrhage, or anti-VEGF prior to surgery. And ideally, anti-VEGF treatment should be done by a surgeon who is well versed with ROP treatment. We usually use a 30 gauge needle, and the distance is 1 to 1.5 millimeter away from the limbus under topical anesthesia. Ideally should be done in the operation theater. Baby is sick, we can do the procedure in the NICU itself. The important thing is the direction of the needle has to be vertical. so not to hit the lens. And again, we have to also take care not to go too deep because it can hit the retina also. So any of the drugs, Avastin, Lucentis, Eylea, all of them can be used. So current status is that Avastin is the most commonly used drug worldwide, and the efficacy was established by beta ROP study. Lucentis is approved for ROP in India, European Union, Japan after results of Rainbow study. In US FDA has only approved Eylea after results of Firefly study. And Resumab, which is a biosimilar, has been provisionally approved by DGCA for use in ROP pending a phase 3 study. And this is an example of baby presenting to us with aggressive ROP. Here we chose to give bilateral intravitreal Avastin first, and we waited for 4 weeks. So we can see the vessels growing into the zone 2. We are seeing some sawtooth vascular shunts, and then we did laser to the avascular retina. Now, what are the problems? If we just give anti-VEGF and leave the baby, so what happens is that peripheral retina remain avascular in lot of these, majority of the babies, and there can be late disease reactivation or detachment of retina and atypical neovascularization. So to give an example, this is a baby who presented to me at like 18 months of age. He had received Avastin elsewhere. So what we are seeing here? So we are seeing fibrous tissue on the optic disc, both the eyes. So lower down we are seeing the left eye where there is a macular drag, and the peripheral retina we are seeing it's practically avascular, and we are also seeing residual ridge tissue. So at 18 months of age, so I did laser treatment to the avascular retina so that further worsening is stopped. So role of surgery, Dr. Simmer will discuss. So usually the trend is 23 gauge and 25 gauge vitrectomy. Lens sparing vitrectomy is done if we have stage 4A more than 3 clock hours, stage 4B ROP, and lensectomy vitrectomy for stage 5 ROP. And this is a case from PGI group, and wonderful results can be obtained in stage 4B ROP. And primary prevention of ROP is very important. Not only with the timely screening, but also, improvements in the neonatal care. So what is important is regular use of, as far as the NICU care is concerned, use of antenatal steroids, delayed cord clamping, and most importantly, the use of blended oxygen, blenders to blend oxygen and air, so that the babies are not on pure oxygen. It's a blended oxygen, and the saturation is kept between 90 to 95%. And using non-invasive modes of ventilation and avoiding unnecessary use of the blood products, and also prevention of sepsis and sensitization of the NICU staff. So to summarize, so we follow in India the RBSK guidelines, early screening at 3 to 4 weeks. The first screening should be done between 3 to 4 weeks. The classification is according to the international classification of ROP, and the laser treatment guidelines according to the early treatment of ROP trial, and confluent laser is a mainstay, and anti-VEGF drugs are to be used usually in combination with laser for aggressive ROP, and surgery for advanced stages of ROP. Thank you.